Thank you very much. I'd like to draw your attention to this recent number of Arthroscopy, the December issue, where the question of Latarjet and arthroscopic Latarjet is very thoroughly discussed. And I point out 3 of the papers that you can find there that I really recommend you read. It's very interesting. I will very briefly, I will just skip these slides because the former speaker told everything about the Latarjet procedure and the history about that. We know what we are trying to do. I just jump to the arthroscopic Latarjet, which was first popularized by Laurent Lafosse in 2005. And then later by Pascal Boileau in 2008. It's a little variation in their techniques. And the initial technique of Boileau was more kind of a Bristow procedure. Now he has more a Latarjet procedure, but with, instead of screws, he use these buttons, as you know. Both of these inventors of the procedure have revised their procedures on multiple occasions after the first announcement. And what we need to know is that there have been reported numerous complications. Some of them have not been reported, and some of them very seriously, very serious. Actually, a nerve transection is a disaster and has been reported. Treatment of shoulder instability at my hospital, Oslo University Hospital, it's about 100 surgeries a year. Majority of the patients are treated with a Bankart or a Bankart plus remplissage. The problems, however, we encounter are young males in contact sport, recurrent dislocations after former surgery, the hyperlax patients, patients with significant glenoid bone loss, and those patients who have deficiencies in the soft tissues. I call it insufficient ligament labrum complex. They're also a major problem. What are the possible theoretical advantages of arthroscopic versus open technique? Well, a French study showed that the only difference they could find was that the patients had less pain postoperatively. You may suspect that or expect that there will be less scarring and less external rotational defects. It's an arthroscopic procedure, so per definition, there would be lower postoperative infection rates. The hope was that the graft positioning would be more precise to avoid osteoarthritis. And another thing which is rare, because these things is rare between females, but cosmetics with a big scar in the shoulder is not what a young lady wants. So those ladies we have operated have been very happy with the small arthroscopic scars. The disadvantage with arthroscopic technique is that it's technically difficult. In most hands, it takes longer operating time. There is a risk of severe complications if there is a lack of technical skills. And insufficient fixation has been a problem with some of the current devices. So we started out in Oslo after many years of doubt. We finally decided we would start, and we started 3 years ago. We decided to evaluate the process very thoroughly and limit the surgery to 2 operating surgeons. We wanted to register the operating time. We did a pre, post, and 1-year follow-up CT scan. And we do the VOSIS and constant score pre-op and 1-year follow-up. And we also designed a scoring system for graft positioning. A few technical issues, positioning and portal placement. We like to do this in beach chair. I think it's easier to do this operation in beach chair, although it has been described, it can be done also in lateral decubitus. What we have done in our hospital due to our anesthesiologist is that we start out with only the first part of the operation when we have the arthroscope in the posterior portal in beach chair. And after that, we turn the patient down to supine position. This means that we can lower the blood pressure, and theoretically, we have less bleeding, and we have less risk of hypooxidation to the brain, injury to the brain because of too low blood pressure and too low oxidation. So this is the position we use. I've lined out the portals we use. They are the same as described in the original technique, with 6 anterior portals and 1 posterior portal, as you can see on this picture here. The first step is preparation of the capsule and subscap. There are debates ongoing if you should take the capsule away like Lafosse does, or if you should keep the capsule there and suture it back at the end. The final answer to this is not yet there, so the jury is still out on this issue. We follow the Lafosse technique and take away the capsule and visualize the joint side of the subscap to identify the level of the split. We also put a marker, as you can see here, on the cartilage at the 3 o'clock position, so that we can have an idea where to put the graft at the later stage of the operation. Then we try to prepare the bed on the scapular neck to have some cancellous bone for the bone block to heal back to. Next part is development of the subpectoral space and the portal placement and the pectoralis minor release. It's very interesting to find that you can also, we thought we could only do arthroscopy in a contained environment that's inside a joint, which is for sure not true. You can easily extend arthroscopy to other non-contained environments, and you can have a good vision and a good overview of the whole area. So here you can see on the upper left picture, here's the coracoid process and the conjoint tendon, and we have developed the subdeltoid space here. Underneath here, we put in 3 needles, which marks the 3 anterodistal portals. And here you can see the split where we take the pec minor off the medial side of the coracoid process. Then comes the preparation of the coracoid. You really need to take off the soft tissue to really visualize the bone so that you are sure that your tunnels are placed in the correct position with sufficient bone each side. Further on preparation of the coracoid, we make fracture weakening with a chisel, so that we can harvest the coracoid process with a clean cut. We drill the holes and we use top hats. We change in the beginning we had top hats in both holes. We stopped doing that and only now in the distal hole. I'll come back to why we did that. Next, which is very, very important, is then the visualization of the neural structures. First, we always visualize the musculocutaneous nerve, which you can see here. Here is the coracoid process. You do take off the pec minor, and right underneath there you find the musculocutaneous nerve. I think it's very important with this arthroscopic technique that you visualize the nerves. Then second, after you have osteotomized, we go and find the axillary nerve, which is also very important because you will see when you create the split in the subscap, sometimes you end up very close to the axillary nerve, and you need to have this visualized when you make the split. This is then the split preparation. We use the traditional technique with a switching stick from behind at the pre-dissected area in the subscap. And we visualize that we can see that the axillary nerve is protected from the stick. And then we make the split with a radiofrequency device. We try to stay in the muscle. This is what we want to achieve. We want to have a bone graft that is situated between 2 and 5 o'clock position, that has bicortical screw fixation, and is never more lateralized than the joint line. Especially this is very important. And if you see a small detail here, you can see that the erosion is not at a 90-degree angle to the joint line. So that leaves us with the option, should we take away the bone that's there to have it parallel to or 90 degrees to the joint line, or should we just prepare, leave that, and have this position? Because if you put it on the existing erosion surface, you will definitely be prone. You will have a graft that is placed too lateral, and that is, in many cases, a disaster. That will lead to osteoarthritis. So we tend to be rather a little bit medial than too lateral. That's very, very important. But this case is probably also within the limits of what can be accepted, whereas this case, you can see it's a little bit prone, but if you calculate the normal depth of the cartilage and see that it's only 2 millimeters prone, it's probably not prone to the actual cartilage and the joint line. But this is a thing you need to be focused on. Sometimes it's not perfect. Here, one case, a young lady where there was a huge defect and a small graft, and the standard screws were way too long. So they are protruding more than 1 centimeter out on the back. And this caused problem, and we had to remove the screws later on, after it healed. And the other case here, you can see there is some resorption of the proximal part of the graft. This is another case where you can see there is apparently a loose inferior screw because there is a tunnel widening. And there again you can see the case with resorption on the cranial part of the graft. So what are the results in our series? We've done now a total of 69 cases. We have not in any single case we have had to change our plans. We have done and gone through the arthroscopic procedure in every single case. The operating time for the first cases, the first 5 cases of the 2 operating surgeons was a mean of 157 minutes. At midterm, we checked and we had 124 minutes. And then we checked again the last cases, again 5 cases of each surgeon, and the mean operating time is 125 minutes. So you see we haven't made any progress during the 30 cases when it comes to operating time. What about the results of WOSI score? These are preliminary results because we don't have follow-up of the whole series at 1 year yet. But we had, the first patients had a WOSI score pre-op of 48. The midterm patients, which we have followed up, had 46. Post-op, 78 and 80, and the difference 30 and 34. So you see, not really a big change. So it seems that these results are pretty good compared to the results from the Norwegian Instability Registry published in ACTA some years ago, where they had, this was Bankart repair, primary cases, 51 pre-op and 75 post-op. Revision cases, 48 and 64 respectively. And remember, about half of the cases we do Latarjet are revision cases. So we think our results are pretty good. It seems that the change from the early patients to the later patients is that we do it a little bit quicker, but even in the beginning we were doing it sufficiently and we were doing it in the right way. So what are the results summarized? We definitely have extended operating time compared to open surgery. We have high VOCI scores as 1 year. Cosmetics are improved in, at least for the females, they appreciate this. I'm not so sure about less pain. I think pain is a very difficult thing to judge. It's so individual. And you probably know the publication where they asked patients who were undergoing a rotator cuff repair, and they tried to find any connections between the procedure, the number of anchors, the size of the tear, and the post-operative pain and function. And the only relation they could find was that those patients who preoperatively reported they have a very high pain threshold, they had much, much more pain post-operative than any other. So pain is a difficult thing to judge. We've had no serious complications. 3 patients we had to reoperate. They have all been successful, 2 of them due to stiffness. They were the early series, and 1 due to malposition graft and screws. We have had 5 graft fixation failures. 2 were detected immediately post-operative and successfully reoperated. 1 was detected at 1 year follow-up with very good function and was stable. And 2 patients, 1 at 4 and 1 at 10 weeks. The first at 4 weeks was a patient with very difficulties with controlling his epileptic disease, so he has repeated seizures. And as you know, no surgical reconstruction technique is stronger than a seizure. The other one went snowboarding a steep mountainside at 10 weeks. This was not according to our recommendations. And he fell, had a high velocity injury, and redislocated and broke the graft. What have we learned? Well, we have learned that the subscapularis split should not be placed too high. In the beginning, they told us we should put it between the upper and the middle third, which is apparently not the correct position. You should have it between the middle and the lower third, at least in the lower part of the middle third. We have no top hat in the proximal hole because we see quite regularly that there is some resorption of the proximal part of the graft, and then it's easy to remove just a screw. If there's also a top hat there, it's more complicated. We haven't had to do this, but it's a topic of concern. Avoid too distal position of holes in the coracoid because it's difficult to decide where's the tendon, where's the end of the coracoid, and you can break out if you're too distal. So better move a couple of millimeters proximal. And then, technically, drill the distal hole in the scapular neck aided by the plastic guide before graft is passed through the split. That is very helpful for moving the graft in there and also preparing the graft before you fix it. Cannot overemphasize how important visualization and working conditions is if you start out doing operations like this. There was earlier today a picture of a complete readout like this guy has. When he's looking around, he has a complete readout, which is the most feared complication of an arthroscopic surgeon. Whereas this guy has a good overview, good working condition, and can helm his ship to a safe harbor. So visibility and working condition means controlled bleeding, meticulous hemostasis with the RF probe, hypotensive anesthesia, cerebral perioperative oximetry, and an excellent arthroscopy pump are all mandatory. For the portals, exact positioning of portals is very important. High number of ports, you need 7 at least, and you have to minimize fluid leakage. Thank you very much.